Good morning, everyone. I'll try to be as concise as possible. So I have no disclosure to this talk. So we'll start with the case. Mr. AJ is a 52-year-old who has paroxysmal AFib. CHAD 65 is 0. He is not on any anticoagulation and has no bleeding history. He has a positive family history for coronary artery disease, diabetes, dyslipidemia, and he has typical anginal pain, and then has a positive stress test. Had an angio, had a PCI to the RCA with 2 overlapping drug-eluting stents. So how are you going to treat him? Should you give him DAPT with anticoagulant for 12 months, so triple therapy? Should you give him aspirin for 1 month and clopidogrel plus oral anticoagulant for 12 months? Should you give him dual antithrombotic therapy with clopidogrel and oral anticoagulant? Should you think about dual antiplatelet therapy only without oral anticoagulant? Should you give him potent P2Y12 like ticagrelor or prasugrel with oral anticoagulant, or should you just give him aspirin for 1 day, clopidogrel and oral anticoagulant for 12 months? I wish we have a pool. So another patient presented with anterior MI and had AFib. So he is 75. He's on apixaban for atrial fibrillation with CHADS 265, score of 3, has no bleeding history, he's diabetic, hypertensive, and dyslipidemic. And he had 1 stent to the LAD. To make it simple, it's just a single vessel disease. So how are you going to treat him? Same options. So we'll start with the nomenclature. What is DAPT? Is a dual antiplatelet therapy. You use aspirin and clopidogrel or ticagrelor or prasugrel. What is DAT? Is a dual antithrombotic therapy. Preferably you use clopidogrel and oral anticoagulant. What is TAT? Is a triple antithrombotic or antiplatelet therapy with aspirin, P2Y12 inhibitor, preferably also clopidogrel with oral anticoagulant. And what is PCI is a percutaneous coronary intervention, and OAC is oral anticoagulant. The background about this talk is there is about 10% of patients who have PCI will have concomitant atrial fibrillation or concomitant venous thrombotic event, or a thromboembolic event like PE or DVT. Choosing antithrombotic regimen in this patient is very challenging, and most of the time you have to think about it in patient-specific cases. There is no one-size-fits-all. And there are 4 potential scenarios. You can have prior AFib, and then patient comes with ACS or stable angina needing stent. Can have a new onset in a patient who's taking dual antiplatelet therapy, and you can have a patient who have VTE and will need a stent, or you can have a patient who develop VTE and already on dual antiplatelet therapy. This is a very busy slide. It's about the interplay between the platelet, the receptors, the inflammation, the coagulation, and each medication. So for the time sake, I will just skip this. But there is the reference here if anybody wants to share it. There are 3 decisions that you need to make in making a plan for the treatment of this patient. The decision about anticoagulation, and this is based on patient's score, the CHADS 265 or the CHADS VASC or CHADS score. And then the other decision is about the antiplatelet. What are the antiplatelet that you want to use and for what duration? The antiplatelet therapy decision is based on ischemic event, and the duration is based on the risk-benefit ratio. So when you are considering a PCI to a patient with acute or stable coronary artery disease, you have to think about local ischemia. You have to think about platelet or plaque progression. You think about systemic ischemic event and bleeding. And as you can see from this slide, the most important period is the first 3 months. And what is even more important is the first 1 month. So in the first 1 month, you have to make sure you prevent patient from having local ischemia, you prevent patient from having progression of the plaque or the disease or destabilization, you prevent the patient from having ischemic event, and you prevent patient from having bleeding. So it is not an easy decision. So you have to think about these 4 pillars. And this slide also tells you that the thrombosis risk in the first 30 days is way higher than the bleeding risk in any patient with acute coronary syndrome. This is different than in patient with stable coronary artery disease. And then after 1 month, bleeding risk is actually higher. So for patients with dual antiplatelet therapy, if you want to make a decision about long-term or a prolonged duration dual antiplatelet therapy or shorter duration, you have to think about 2 scores, DAPT score and PRECISE score. So DAPT score is a 9 items, clinical and procedural. If the score is higher than 2, you have ischemic event. And the PRECISE score is for bleeding risk. Okay, it's 5 items. If the score is less than 25, the risk of bleeding is low. And this diagram can tell you which patient can go for prolonged dual antiplatelet therapy, those who have high DAPT score and low PRECISE score. So DAPT score more than 2, PRECISE score less than 25, they should go for standard therapy and probably for longer duration. If their DAPT score is low, like 0, and their PRECISE score is 0, they should go for short duration, regardless of the event. So triple therapy, what happened and when did it start? So basically in the 2013, there was WASP trial checking about dual antiplatelet therapy with warfarin, and they found that there is no difference in thrombotic event if you use dual therapy, like short duration of aspirin, then clopidogrel and warfarin, compared to longer duration, but there is reduction in bleeding. And then ISAR triple trial has shown exactly the same. But it was shorter duration, 6 months and 6 weeks. Then there is Pioneer AFib. It tested non-valvular atrial fibrillation with patients who received stent. It is a complex process. They had 3 groups. Group 1 is 15 milligram rivaroxaban, reduced to 10 if there is kidney disease. And they used P2Y12 inhibitor. 95% of the P2Y inhibitors were clopidogrel. And then there is another group that used 2.5 rivaroxaban twice a day. And a third group which used warfarin based on INR. And they showed there is a difference in the major bleeding in favor of rivaroxaban, and there is no difference in thrombotic event. Augustus trial is the largest trial that tested patients who received dual or triple therapy in patients with AFib. I'm sure probably most of you are familiar with that, so I'm just going to skip and go to the findings. So they found that there is a significant reduction in the major bleeding with patients who receive apixaban compared to vitamin K and patients who receive placebo compared to aspirin. And then they found that there is about 11.5 absolute risk reduction with a number need to treat of 9, comparing patients who receive vitamin K and aspirin compared to placebo and apixaban, with no major differences in thrombosis. With regards to death and hospitalization, there was also a reduction with the apixaban group. And then there is the fourth trial, which is the INTRUST AFib trial, testing edoxaban, and it also showed that there is a reduction in bleeding, as it's shown in this Kaplan-Meier curve, that the p-value for non-inferiority was significant, and there was no difference in thrombotic event comparing edoxaban to warfarin based on their trial. So their primary outcome was to assess bleeding. The safety outcome was to assess thrombotic event. Now, what about the guidelines? The guidelines are everywhere. There is European, North American, Chinese. We unfortunately don't have one. Hopefully we'll work on one if everybody will be happy to support. The European has a default strategy. They use a triple antithrombotic therapy for 1 week or less. They go shorter in acute coronary syndrome. And after that, they go with dual antithrombotic therapy. North American actually prefer at least 1 month of triple antithrombotic therapy with the use of aspirin for a minimum of 4 weeks, so 1 month, and preferably up to 2 months. The Chinese guidelines prefer to use aspirin while in hospital. Once they are discharged, they stop the aspirin. And truly, there is really no major thrombotic event if you use any of these. But the bleeding is probably higher in high bleeding risk patients. This is a busy slide, but this is to summarize all the guidelines. Unfortunately, the guidelines are lacking. The latest guideline was 2021. They totally disregarded the finding of the Augustus trial and Entrust trial. So what I think is likely to be the easier to remember is the Canadian guideline, although it is from 2018. So they choose patients with atrial fibrillation who have elective PCI, like stable coronary artery disease, or patients who have no high-risk features. And they describe them very well, what are high-risk features. And then they decide about what is their CHAD score, and then they go with an algorithm. So if the CHAD score is 0, they give aspirin and clopidogrel. And sometimes they will suggest stronger dual antiplatelet therapy like aspirin and ticagrelor. And if the CHAD is higher than 1, then they will go with oral anticoagulant and clopidogrel. And sometimes they will just tell you, do not use aspirin. What if the patient has acute coronary syndrome or high-risk features, then they will suggest a triple therapy. Now, what they put in their guideline is they can use apixaban 2.5 in the triple therapy. I would vote against that because 2.5 is not protective of thrombosis or thromboembolic in patients with atrial fibrillation. So if you are going to use triple therapy, you should use a dose that is preventable for thromboembolic event. This is what they suggest with their dosing, but again, all the guidelines are lacking with regards to the newest data. These are the indications for reduced dose, as my colleagues already specified, for apixaban and edoxaban. And these are 2 articles. This one was published in 2019, and this one was published in 2022, which I would strongly recommend for anybody who would like to read more about antiplatelet and anticoagulant treatment in acute coronary syndrome or stable coronary artery disease. So take-home message, one size fits all is not ideal in patients with atrial fibrillation and PCI. You have to always consider the balance between bleeding and ischemic event. Stable coronary artery disease with AFib can go with only oral anticoagulant based on the AFFAIR trial. And if you want to be due diligent, you can give them one short duration of antiplatelet, single antiplatelet. Clopidogrel is always preferred in the triple antiplatelet therapy or the dual antiplatelet therapy. However, in special circumstances like diabetic who are at very high thrombotic risk, you can use actually ticagrelor based on the Twilight study. The shorter the duration of the triple antiplatelet therapy, the better with regards to the risk of bleeding. For ACS, you can use aspirin for 1 or 4 weeks. And if there is a high bleeding risk, then you can use it only for 1 day, the day of the anticoagulant, the day of the event or the PCI. And after that, you can stop. For stable coronary artery disease, there is no need for triple antithrombotic therapy, only dual antithrombotic therapy for 1 to 3 months, and then OAC alone, or OAC actually from the beginning. Thank you very much.